So time to start the next session. Good afternoon everyone, and the course entitled Dmek Made Simple for the Beginners. So if you see these two pictures, there are differences but not much. On your right hand side you will see that it is a Dmek. On left hand side it is DSEC of a same patient about 4 years apart. And you know that you will like the picture on the right hand side. Patient is happy, the surgeon is happy, vision 6:6. So when you see DSEC, it is always between, we are adding tissue of 80 to 120 micron more, but we know that this is not anatomically perfect and also visually. So why Dmek? Dmek is perfectly anatomical and higher chances of recovering 20/20 or better vision. With why it is like that? And this is US data, and if you see the lowest row, you will see that Dmek in last few years, it is increasing tremendously in US domestic use. And if you see that in last 6 years, actually it has doubled. So this year probably Dmek will surpass DSEC in Western world, especially in US. In India, probably more than 100 surgeons are doing EK in any form regularly for last 10 to 15 years. If you see the figure, this is from iBank, we have got these figures. Last year, 21-22, we have done less than 3,000 EK procedures, and among this, Dmek is only 18%. With this note, I call upon our faculty panel, Dr. Shoham, Rajesh, Dr. Namrata, and Dr. Revati. Revati, are you here? So, none of the speakers has any financial interest to disclose. So, I'll start with our first speaker, Dr. Shoham. He will be speaking on case selection part. Dr. Shoham, he will present from you. Thin, very thin. So it will ballroom, I mean general. But Dmek, this look.
A very good afternoon, everyone. So I'll be talking about the Dmek indications and case selections. I have no financial interest. So simply put, for any endothelial dysfunction, Dmek can be an indication as the same as DSEC and DSAK. However, there are minor things that you have to keep in mind. One of the best criteria for starting is a PBK with a good anterior chamber anatomy. If there is sulcus fixation IOL, there might be problem in centering the graft and also retaining the air tamponade. In very advanced and long-standing PBKs, Dmek might be possible. Initially, you might think that the visibility is too poor to do a Dmek. So you can do a two-stage, do a epidebridement and a BCL first. This improves your visibility, intra-op visibility tremendously. And then you can go for Dmek as a second stage procedure. In cases of pseudophakic corneal edema with following tasks, few things to keep in mind. There is more chances of bleeding during doing the inferior PI using a vitrectomy, more pigment release, higher chances of developing rejection and glaucoma in the postoperative period. And also there is higher chances of fibrin release, which might interfere with the unfolding of the Dmek scroll. In cases with ACIOL, Dmek is possible as long as the good anterior chamber depth and ACIOL stability is maintained. Say for someone who has had good vision for 10-15 years and then went on to develop a corneal decompensation later on. But however, these are cases which tend to fail earlier, and so in these situations, it might be better to do an IOL exchange initially and then do DMEC at a later stage. Can be a scleral fixated or an iris claw lens. FECD in eastern part of in India, FECD is one of the very common causes of developing corneal edema, either pseudophakic or phakic. So these are again excellent choices for starting off with DMAC. And if you're doing Fuchs, if you're doing attempting only cataract, make sure that you tell the patient about a probable transplant in the future. And if it is a very young person, you can do only the DMEC in a phakic condition and later on do a phaco few years down the line. This is also again a very good indication post-dissect failed grafts. Just be very careful while removing the old failed graft because they tend to bleed at the angles. Post-PK failed graft might be challenging. You have to make sure that the posterior graft-host junction anatomy is well maintained, otherwise that will interfere with the graft attachment. So in this respect, probably the larger therapeutic grafts is more useful to start off with. Post-trab and post-tube shunt glaucoma patients can be taken up, but the air tamponade is difficult because air tends to escape through the pre-existing opening. And also the graft size has to be slightly smaller to make room for the tube. Other rarer indications would be posterior polymorphous corneal dystrophy, the congenital hereditary endothelial dystrophy. Aphakic eyes, again, might want to do a secondary IOL and then take it up. Eye syndrome, higher chances of rejection and later on developing glaucoma. Post HSV, the prophylaxis has to be maintained. So the contraindications for beginner is something like this, where you have a lot of vitreous in the anterior chamber, there is lot of iris deformity, ACIOL which is decentered, this is better to go for an IOL exchange, or overall poor visibility. Again, patients like this, severe Fuchs with a lot of stromal scarring, these would actually require going for a full thickness graft, and someone with a very large dilated pupil. So if you look at the indications in the Western world, Fuchs dystrophy is the commonest, followed by corneal decompensation, and then failed grafts, and also the miscellaneous. In India, however, when we have analyzed our data, almost 40% is due to post-cataract decompensation, and the second highest indication is FECD. Failed grafts, HSV, and eye syndrome contribute significantly to the indications. So to summarize, ideal cases can be early Fuchs or pseudophakic corneal edema with a good anterior chamber anatomy. The central round pupil and a stable IOL is one of the prerequisites. Ideally, no vitreous in the anterior chamber. And a little bit about your workup and pre-op evaluation. So as beginners, it's always better to maintain an Excel sheet so that you can track how your patients are progressing and how your complications are doing over a period of time. So things to note in that would be the diagnosis, the visual acuity of both the eyes, and the diagnosis of the other eye. Sometimes in cases of PBK, gut data or Fuchs might be missed, which is evident when you look at the apparently normal eye. The lens status, and if there has been any prior corneal surgery. In prior glaucoma surgery, it would be good to keep them on the anti-glaucoma medications and record the intraocular pressures, and also make a note of any prior intraocular surgery. If pseudophakic, then you have to make sure that the IOL is well-centered, stable, and also if there is PI patency of the PI from any prior glaucoma procedures that might have been done. And investigations, what needs to be taken care is you can do a posterior segment evaluation using either an ultrasound or, if possible, macular OCT through a hazy cornea, biometry from both the eyes if possible, anterior segment photography for documentation and patient counseling. ASOCT is probably the most important tool to sort of make sure and plan our surgeries. This is a debatable topic, phakic corneal edema, so whether to do a Dmek triple or not. So usually what we follow at our center is anyone above the age of 40, we tend to go for a triple. Younger patients, we can do a Dmek alone, but again, cataract develops early due to all the intraocular manipulation and steroids. In eye syndrome, it's always better to take the lens out because that improves in the later on glaucoma control. IOL selection, it's a hydrophobic acrylic, usually white lenses. Multifocal lenses better to avoid. Toric lenses definitely can be considered. The target myopia of 0.5 to 0.75, which is slightly lower than what you would do in DSEC. Specular microscopy of the other eye again can give us clue to why a PBK developed. So definitely sometimes gut data or a low cell count in an apparently normal looking cornea is detected. So to summarize this, so definitely record both vision and intraocular pressure. Anterior segment OCT is the most relevant tool, and other eye specular microscopy. Go for a single piece hydrophobic monofocal IOL with a 0.5 to 0.75 myopic target. Thank you very much.
Yeah, after that talk by Soham Basak, we have Dr. Samar Basak talk about donor scroll preparation and some of the basic steps in Dmek. He has maybe the largest experience of doing Dmek in India, very large volumes, and he has published extensively both in Indian and international journals. And he has given presentations all across India, and he has trained a lot of surgeons as well. So over to you, Dr. Samar Basak.
Thank you, Rajesh. I do not have any financial interest. So I will be dealing two parts. One is donor preparation and another is the donor insertion and unfolding. But major part of unfolding and other types will be tackled by Rajesh also. So initial ideal donor tissue should be, I use any type of tissue like MK medium, cornisol, optisol, preserved tissue. Donor age preferably 55 to 75 for the beginner surgeon. Endothelial cell density must be 2500 or more with good morphology. You must check the morphology also. The number is not that important. Standby optical quality tissue for first few cases. The first hurdle of Dmek is donor preparation, and in US or Western world, they are privileged and they use all sort of 5P type of Dmek graft. They get everything ready, but India, all surgeons are preparing Dmek graft themselves, except recently Ramayama International Eye Bank has started supplying pre-peeled, only pre-peeled Dmek tissue to other surgeons. And donor damage or donor preparation failure is around 1 to 4.3%. So there are many methods of peeling technique, separation technique. I prefer this double diffraction. And these are my simple instrument. I use only this normal Teflon block, not expensive tools. And you need a S or F mark. You can do it with the ink and Sinskey hook, but if you have a regular, you have a very clear S mark. So I always prepare my donor tissue. When I do the PI, I put the air because I get time, that 5-7 minutes of air tamponade time, because this air helps to stop bleeding, to clear the edematous cornea to some extent, and it also saves my time. So that 5-7 minutes is important for me for donor preparation. This is my old video, and you see that it is very simple. The peeling is very simple. If you do 5 or 6 in a wet lab, you can do it very easily. And when this thing is very important, you first separate the extreme periphery. Then you need lot of trypan blue staining, find the edge of, and you can do 100 without any suction type of trephine. The bed should be dry, otherwise it slips. So this is the usual method of doing stromal punch with a 3 or 2.5 millimeter. Flip the cornea. Sometimes as you get this kind of lovely lid kind of thing. So you just take 7, 7.5. You decide your donor size beforehand, and accordingly you do it. Peel it, then again stain it this stain for 1 minute or so, and you shift in a petri dish and load in a injector. This is a beautiful video. You see that you can use this instrument to separate the DM endothelium from the posterior stroma, and this is so useful that you see that surgeon is just rotating the thing. This is the junior surgeon is doing, rotating the thing, and you can easily actually, and if you separate 360 degree, I am telling you no case there will be a radial tear. So these are, we have shifted from McPherson to this, any hook, that way a chopper can do this job. And sometimes you find a tear, sometimes, this is my old video again, and there is a tear, so we make a small tick sign or Nike sign, and make it a round shape so the tear will not extend up to the middle. So that is very important, and then you continue. If you have a multiple tear, you do multiple type of round edges so that it will go forward. So this is my data published in our journal, Cornea Society Journal, this month only, last month only. And you see that there is a huge difference of donor is between 37 to 92 years donor. And you see the overall tissue damage during preparation is only 1.4%. And this is a separate concept. I used to follow this concept, the peripherally trephine. It is published in Cornea Journal, and I am using it most of my cases. It gives, if you compare with central, it is peripheral. So peripheral endothelium has more cells than the central. And this is typical example of one patient bilateral, and you see that it is unintentional. And I realized that time that peripheral is doing much better than the central. Then we have described this BCL. This is during COVID time. To save one tissue is to be used for the other eye. So one tissue for 2 eyes, one for Dmek, one for DALC or other purposes. So during the COVID time, lot of innovation has happened. So we can use the anterior. This anterior stroma is basically virgin anterior stroma. So you can use up to 9.5 graft and use for multiple purpose for your second patient. This is a thing I learned from Rajesh. This is also another way of putting stamping, that you put a bubble and write, again put an S. So you had again, so to say, more than 8.5 or 9 millimeter, and you put an S mark, then you do the punching. This is last one I have again learned from Rajesh. This is fluid based. Fluid based, this is, I have not tried, but Rajesh has told me you can do it in younger donor. So that is very important. It's just like you are creating a big bubble on the posterior surface with a fluid. Fluid means trypan blue dye, and you see that there is the creation of bubble, and you have more zone. Now you puncture it and you just use it. So these are some things, and again during COVID I have used pseudophakic donor. Pseudophakic donor, this is after phacoemulsification donor, and you see that pseudophakic donor you have to be very careful. Where is the your sorry, I'll go back. So you see where is your the three mark of incision. So so you see the mark of incision from externally, you eccentric just this template mark towards eccentric region. From inside you can also notice the area of marking. This tissue has got 1800 cell count, 2800 cell count. So you stain it, and then as usual you do peel, but you stop at the junction where the side port is. So stop halfway and then go usual. When you punch it, you go little eccentric. So your graft size will be 7.75 or 8 millimeter depending upon these are the, see the marks. So pseudophakic tissue you can use it if it gives a, last COVID period we have done about 50 such kind of tissue. So you have several. So in summary, the Dmek graft preparation is not that difficult, required backup tissue for initial few cases. Preparation failure difference series 1 to 2.4%. Any kind of media you can use. Take help from the masters, and some YouTube video will be very helpful. But always prepare yourself, because you can see that what is the damage previously happened before taking the graft. Like in this, there are damaged area you can avoid as far as possible. So if you prepare the tissue, you will harvest the best tissue. My second step is basic step. I do not repeat this. You all know this. The only difference is that I prefer to go little bit posterior limbal, so that I do not put suture. But suture for the beginner is always best, because there are many reasons the graft may come out during unfolding attempt. So you give suture little bit posterior. So that is one thing. Second thing is that DM scoring. When you do the DM scoring, it must be 0.5 to 0.75 depending upon the corneal diameter. And always used air assisted in cases where you have like post VR surgery, SFIOL, SEIOL, where the thing is difference. So that is, and remember that to remove all tidbits of DM from the central part, because that is a cause of donor detachment sometimes. Inferior PI is, of course it is required, but many people are not doing inferior. There are papers, but it is always severe. It prevents the pupillary block, and you can do manually or vitrector, but always put air tamponade to prevent using of blood. And always, this is also important, while you are doing triple procedure, you have to, oh no, this is bleeding. Bleeding, sometimes it is, sometimes you can, there will be lot of bleeding with vitrector. There is you may touch the vitreous space, and there might be vitreous prolapse through the PI. So you must be very careful. This tamponade will help. So donor transfer and insertion technique. Again, there are many techniques. Rajesh will share most of them. I am showing some of my same technique but different orientation. But Whenever that any insertion technique you are using, remember that almost all are same, that the main theme is that there should be less manipulation in the anterior chamber, ease of unfolding, and your endothelial cell loss will be less. Plastic, glass, all are anecdotal reports, all are almost same. People are sending their graft tissue in plastic cartridge, the pre-prepared graft tissue. So plastic is not that bad. So I prepare my own tissue, and it is own injector. It is from sensor multiple, still it is available, and I am also using goiter cannula sometimes. But this preparation is very simple. You just make it. Every day you will have a new injector system in your hand, and every day it is free, and no need to sterilization, no need to autoclave, nothing. I prefer 2cc syringe. This is BD without any rubber inside. It should be smooth running. The syringe is also important, because that cause also lot of trouble. So thorough cleaning is very important before insertion of the donor. You must be clean all hilon. Hilon, we are using hilon, so from the back surface, from the anterior chamber, and also clean the anterior chamber and remove any small air bubble even, because all those things will hamper when the graft is going in, all will hamper the thing. So clear everything, clean blood corners, fibrin threads, and clean the main ports and side port, because sometimes the fibrin threads lying there and that goes in and cause problem. So this is a beautiful YouTube video. You must all watch this. This is by Beltman, but all in dark, lighter color iris, so you see better. But we do prefer, the technique and principle remains same with our darker iris. I used to see all these different type of scroll. I try to, during loading, I try to orient my graft, and there are certain principle, like I try to see the S mark inside the cartridge, and if because we always go in bevel down position, but while injecting you can be bevel down, you can be sideways, you can be bevel up position. You have to rotate your injector system that way. I have done one video, and it was shown in American Academy. So you see the S is reversed, so but bevel down, S is right. So you go, nothing has to do, you just go in, inject slowly, and you are in a right direction, and you just tap it. And this video was made about 5 years back. So you tap it and it will open. So similarly, if you have just, when you see that the S in bevel up position, then you need to rotate. Here you see that S is right in bevel up, you go in, rotate, and then you inject. So Rajesh have a different technique, Rajesh will show, and that is also very beautiful technique. And that is, he does it in goiter calunda. So third one is S is like similarly sideways, you inject, S is right on sideways, so inject in little left or right side, you inject. That is the principle. But whatever you follow, it will actually listen to you about 60-70% cases, but rest you have to manipulate. So check air bubble inside the cartridge. This is very important. Air bubble inside the anterior chamber, air bubble inside the both are damaging for the graft. Then again, Rajesh has again a different system, very elegant, and while injecting you release fluid from the side port, so your graft will not come out, and always protect the main port, and then release more fluid. Now when you are ready, then you can tap to one end, and then you just few taps, it will open. Sometimes if your This thing, it is open, then center it, air, all this thing will happen. Sometimes you see there is a perfect scroll in the cartridge. So you go in, and unfolding can be done only by fluid release from both sides. Just fix it, no tapping. Both sides you release the fluid, and both sides it will open like this. You see, it is opening. You do just little bit of movement, not that much of samba dance kind of tapping this thing. So the air injection is also, I will be talking one line mode that time. And suppose this is just reverse. It is just reverse, sorry. No, this is again same, but it is with the tapping. So it is like this. So same thing, not with fluid release, but you tap, you place the one hand right at the middle. Again, almost same like previous one. It is always, you know that this, you are in a right direction. It is very difficult to see in our eyes, see the mark, asymmetric mark. So air bubble should not be much. It should just like this. So you could see a peripheral rim of fluid. If you give much, there will be more chances of, if you are using air only. Gas is different. I use only air except one or two cases. What I showed earlier, this is just reverse. Now, when you realize when you are trying to unfold it, the S is reverse. I do not know whether you can see it. S is reverse. So you open it little, take the thing to the other side, your preferable side, and then you just inject such a way it flips. When it flips easily, no short, not burst and little, it is a control fluid, and when it is open, you see the typical sign of hat sign, and now you open it. Even you can release fluid from the main port and few stroke, and again the graft is. This thing happen in many times, but sometimes it is taco type unfolding. You again roll it. You are not sure. Now when you are sure, then you form taco type. When you form taco, you pin it one of the distal end, and gradually you tap, and you take on the other way. It needs space to open up. So it opened up, and you see that because of light colored iris, you could see the S in this patient. This is again after half taco, but you see that S is reverse. So you need to flip it before hole open. So when you just flip it, and again when you see, sometimes you realize this is S is right, so you carry on, and beautiful. This was, I showed in live surgery in Italy, and everyone is saying, yes, you are right. But then I put air, and you see that S was reverse. So this happened. Rajesh was the panelist in that. I was operating in Kolkata. The video was shown in Italy. And you see that after, and there was, this is like origami type of picture. Then we stuck for fibrin clot in one side port. Then ultimately I could open it, and it takes little more time. But this all happens in, it is not that easy game. Always you will get like this and open like this. So when you get a right taco, then again you can open it. Sometimes tight scroll. So I have a different mechanism. I take this is a 37 years old donor. I give a short burst type of injection, not slow injection, so that it hits the other angle and it opens little. When it's open little, you get one edge. So when you get one edge, then, and this type of graft never reverse type of scrolling, it never happens. Tight scroll always in the same direction. So you just have little more time, but when it's open, you can completely open it, and it takes time, completely open it, but never deepen the chamber. Again it will half scroll. It will again like this. So this is it. And sometimes the unfolding is fun. Like this patient with older tissue, more than 80 years old. Just I saw the scroll type in my, though not in clear in the Curtis, I just go in, it opens like this. So, and when I am sure that it is open right, so you put air and it is right. So there are several things, and you see that as you can see under your still injector, I mean cannula. So immediate post-op is very crucial. I keep our patient in the recovery room for 1 or 2 hours, then examine. If in first examination you see this fluid clip, this 1 millimeter or 1.5 millimeter, you are happy, send the patient, you don't have to touch anything. But if you see this air is like this, like almost full chamber, you have to burp little air. Otherwise, within an hour, when the block will be gone, then the patient will may have pupillary block. So you release little, and again you get a little fluid level, and after 4 to 6 hours you send the patient home. And we usually check the patient on day 3 or day 3 is my choice is day 3. So in India we need to do a lot of EKs, because we are doing a lot of cataract surgery, 6.8 million last year, and approximately we are adding, so almost 6 to it may be 10,000 PBK every year. Fair number of Fuchs dystrophy, especially in Bengal. Surgical and visual outcomes is just like a cataract surgery outcome. And as a beginner surgeon, we need to start this wonderful surgery. Thank you very much for your patience hearing. So I now call upon Dr. Rajesh Fogla, who is my telephonic guru, I always say. Telephonic or nowadays WhatsApp guru. So we learn from each other since our DSEG days, 2005. So Rajesh.
Thank you, Samar. We can take some questions if you want, if the audience has, and we can. Okay, so I will take off. Yeah, if you have a question, please go ahead. I think she wants to ask.
Glass. That is not a glass injector, that is a cartridge. Sensal multi-piece cartridge.
I'll show. I have a video. I'll show you. You can look exactly
Sensal
what he has
you
prepared.
just break it like that. It is a plastic. AR40 actually.
You can create that with any of your IOL cartridge, and it will go through a 2.8 millimeter incision. Taking off from where Samar is, left in his presentation, I'll be talking about, again, loading, insertion, and unfolding of a Dmek donor scroll. Dmek stands for, decimus membrane endothelial keratoplasty, but I say it also stands for definitely most easy keratoplasty. No financial interest. You can use injectors created by modifying your IOL injectors, or you have dedicated glass injector like the Jones tube, the goiter injector, or the endoglide. Now, looking at some of these injectors, this is from your Alcon cartridge. You can take either the B or the C cartridge. You can take a syringe, put a silicone tubing in the front or your IV tubing set, and the other end of the tube will go inside the Alcon cartridge. So that becomes your Dmek injector. Just make sure that the connection is tight and it is watertight. This was described in a paper published in Konya back in 2014. We did try using it and it works pretty well. The other injector, what Dr. Basak was talking about, is the AR40E cartridge. You just break the wings of the cartridge. You can just, these are a little hard to come by nowadays because the three-piece lenses, J&J is kind of stopping it. But you can basically create that with any. So once you have the tip, take a small piece of your IV tubing or your silicone tubing. One end attaches to the tip of the cartridge and the other end you can attach to your syringe. You can decide the length of the tubing. I don't like to keep it very long because then your donor insertion becomes a two-handed technique. But if you keep your the tubing part a little smaller, then you hold the injector as a single. You can get this. This is again a micro pipette, which is we got that from Amazon. It's used for labs. So you can just cut the tip using a number 15 blade. So you get a fairly small tip opening, which can go through even through a 2 millimeter or 2.2. And the posterior end, you can attach a 5cc syringe. This was a little wider, so we decided to cut the posterior end as well. These can be gas sterilized, so you can make them sterile. And once it is done, you can attach to your syringe and use them for your surgery. And this is again a glass injector. You usually have the DOC one or the Goida one, but this one is available from Georgia Surgicals as well. So that can also be used pretty much similarly the same way. Loading, you can load what Dr. Basak was showing. He was loading it from the tip. You can keep the donor on the corneal scleral rim, but there is a limited amount of fluid, so your nurse has to keep supplementing that well with BSS. Or you can transfer the DM scroll into a glass or a metal bowl, and you can aspirate it from the tip. This works pretty well when your donor scroll is going into a scroll, but if it is remaining open, then sometimes loading from the tip, you may have the shearing effect at the edges of your cartridge and you may kill more cells. In that scenario, maybe loading it from the wider posterior end is better. So you attach the syringe with a silicone tubing to the tip of the glass injector or your IOL injector, and you can aspirate the graft from the posterior end. There's another way of loading it where you can just hold the donor from one edge. As you lift it up, it becomes like a thread, and then you can just push it inside the cartridge as well, either from the posterior end, or here you will see that I'm loading it from the tip. You can just, by capillary action, it'll just slide into your tip of the injector. So you can, there are many ways of doing it, so you can try whichever way works best for you. It's important that once you aspirate the scroll into your injector system, that you look at the open end of the scroll and which direction it's facing, because the delivery of the DM scroll, you would ideally want the open end of the scroll to be facing towards the surgeon and not towards the iris, because that maintains the orientation of the scroll and allows easy unfolding. So the open scroll facing towards the surgeon is the right orientation, but if the open end of the scroll is facing towards the iris, then your graft scroll is usually upside down. One of the problems we face in the learning curve is that it's a fluid-based injection system. So as you're flushing the fluid into the anterior chamber and taking the donor scroll along with it, depending on the volume of the anterior chamber, if you overfill the anterior chamber, as the fluid leaks out either from the main port or from the side port, you can have the tissue either rush to the side port or come to the, try to get partial or total expulsion from the main incision. And that's where the wound construction becomes very important. You will see in this video, I have a wound that's slightly loose. I'm pushing in my graft, and you can see that as the fluid leaks out, so does the donor graft. I'm trying to release fluid from the side port, trying to get the tissue into the eye. The mistake I made was that my speculum was still a little tight, and then I have to push the tissue into the eye physically. So this is something that we need to avoid. So this is the site that of Peter Wellman. It's got patientready.org, and it gives very beautiful animation, and it also gives you surgical videos to show you the different kind of scroll configurations and the maneuvers that you can do to get to unfold it. It's a useful resource. When you get the scroll into the anterior chamber, as you see in the first video with the open end of the scroll facing towards you, you can use a no-touch technique. I like to use 2 cannulas, and 1 cannula basically to stabilize the graft so that the graft doesn't move with the disturbance of fluid in the anterior chamber. And the other cannula tip, you can either tap inside or outside the scroll to create fluid movements which allow the graft to unfold. And once it is unfolded and well centered, you go ahead and place an air bubble. If you have a taco fold, it's obviously difficult to unfold. So giving a small burst of fluid towards the iris can make the taco fold, rotate a bit, and you can get the open end of the scroll facing upwards. And once it is facing upwards, don't keep a deep chamber, because if you keep a deep chamber, the scroll will again rotate. So keep a partially formed chamber, and then you can mobilize the donor using your 2 cannulas to try and unfold it. 1 cannula is usually used to fixate the open end of the scroll, and the other end, like you see, if you tap it outside in rapid release, the movement of the fluid causes the donor scroll to open up. If you have a paracentesis, you can even release fluid from that paracentesis to allow the scroll to open up with the movement of the fluid. Younger donors, which have a greater elasticity, may not open up by pressing outside. Then you have to press inside the scroll. So that's called the Dirisamer maneuver, where you are fixing one edge of the scroll with your cannula, and the other one you're doing a carpet unrolling technique or the drum roll technique, where you push the scroll with your shaft of the cannula and get it to open. Once it's open, you can tap outside the scroll, not over the scroll. And so you don't make the same movements like what you do with a DSEC graft, but you go outside the scroll, and as you tap, you can get the scroll to move. So it basically covers the pupillary area, and then you can go ahead and put your air bubble. If you have a vitrectomized eye or myopic eye with a very deep anterior chamber, sometimes shallowing of the anterior chamber is difficult. In that case, to open up the scroll, you can take the help of a small air bubble, which you put it inside the scroll once you have confirmed that the scroll is the right orientation facing upwards. And then by moving the air bubble, you can get the scroll to open up. Then gently aspirate the bubble without disturbing the DM scroll so that it doesn't scroll back, and you place an air bubble below the graft and get it to open up. You can use the pull-through technique as well. So here you can see that we are stripping our donor DM. We create a trifold, but this is pretty much like folded like a DSEC graft. And once you have folded that, you stain it with trypan blue. And then here I'm using the Sensor cartridge, and the trifolded DM scroll is pulled into the tip of the cartridge. Remember that here it's endothelial inside. So if you touch outside, it's the stromal side, you're not killing endothelial cells. I use a foam tip plunger from the ICL surgery and use it to close the posterior end of the IOL cartridge, and use a microforceps to pull the scroll into the eye, pretty much like a DSEC graft, and put an air bubble in the center, and thereby you can open up the scroll. And this is very useful in eyes which have AC IOL, or if you have a shallow anterior chamber where rotating the graft would be very difficult if it's in the upside down position. There's another such case. Here, it's very important how you direct your AC maintainer when you're using a pull-through technique. And ideally, it should be adjacent to the forceps that you are pulling in. So the flow should be directed towards the graft and not like the manner where I am having in this case. I pull the graft into the anterior chamber, but watch as the AC maintainer flow is going on, the graft tends to make abnormal movements. So I have to take out the AC maintainer and not let go of the graft, because otherwise the orientation will change. We put in some fluid in the anterior chamber, tap, and once I'm sure that the graft is opening up in the correct orientation, I let go of my microforceps, and then I put an air bubble below the graft. So it's good to perform. Donald Tan does this routinely in all his cases. I tried it, but I think that it has a different learning curve. So in complex scenarios, this is something really good. That's the patient. You can see by day 5, the graft looks pretty clear. So what we have changed now is we try to see if we can get a double scroll configuration. So we aspirate our stained donor graft into the wider portion of the glass injector, and then we try to agitate the fluid between the narrow and the wider portion. So as you bring the graft to the narrow part and flip it to the wider part, you can see that it opens up, and then when it re-scrolls, it can go on to a double scroll configuration in about 80-85% of the cases. The second thing we did was we tried to create a unidirectional flow. So we do connect a AC maintainer to the anterior chamber. This is a 25 gauge AC maintainer, which is switched on when I'm putting the tip of the cartridge into the eye. So the AC is nice and deep. Once my tip of the cartridge is inside the eye, I rotate the tip so the open end of the scroll is facing up. And at that point of time, before I insert my graft, the AC maintainer is switched off and it is disconnected from the IV tubing. So now the AC maintainer acts as an egress point of fluid from the anterior chamber. So this we did in a cataract surgery just to show you that when you do that, you can see the trypan blue dye flowing out of the AC maintainer. So here you can see that I'm inserting my donor into the anterior chamber. Once the donor is inserted, the fluid is going out of the AC maintainer. So the chamber shallows, which captures the orientation, maintains the orientation of the scroll. I do close my wound. I'm not as brave as Summer to leave my wound open during manipulation. I slightly deepen the chamber, and then you can see that's a double scroll configuration. I just secure the center, and as I tap the periphery on both sides, you can get the graft to open up, and then you can put an air bubble below the graft to complete the surgery. This is another similar case. Watch that I put my tip inside the eye, then I rotate so that the open end of the scroll is facing up. Now I stop the AC maintainer, ask the nurse to disconnect it. And now when I inject my donor graft, you can see that it goes in very controlled manner. And even when I bring my tip of the inserter out, the graft is not trying to rush out of the eye. And then you can tap at one end to open up the scroll, and then you can do the same maneuvers what I've discussed earlier, that you catch one edge, and as you tap, here I'm using the carpet unrolling technique, and you can open up the scroll, put an air bubble, and complete the surgery. This is something about flipping over, which Summer has already showed, so I'll bypass. This is the cannula that we designed, which has two side ports. So here, basically, if you have a young donor and a tight scroll, you can put the cannula inside the scroll, and as you give a burst of fluid, the lateral burst of fluid opens up the scroll, converts into a open scroll configuration, and you can complete the surgery. Marking is important. You can create an S or an F stamp, or you can put this triangular notch mark going in a clockwise direction, or put asymmetric marks. You can even create the mark over an air bubble, as what Summer had showed you, is that we fold the donor, put a small air bubble, and over this air bubble we can put in our F or S stamp so that you don't have to make a stromal punch. You can use the handheld slit lamp or the intraop OCT, what Namrata would be talking about. And so that's in conclusion about unfolding, loading, insertion, and unfolding of the Dmek graft. Thank you. Thank you for your patient hearing.
Thank you, Rajesh. Wonderful, as always. And we can have 2 questions from the audience. Then Namrata will be speaking. Any question from the audience for Rajesh? So everything is very clear to you. So many examples are there, a lot of examples.
Namrata, I'll just show one video.
What happened, Rajesh? The question is, do you do?
Men incision.
So I think Dr. Basak has taught us to do superior. So we
No. It is not that. It is my problem of going temporal. It is my physical problem. So I do cataract surgery also superior. I have a different kind of table for myself. I have designed it. So that's why there is nothing but one thing I understand, that both that temporal and superior, why I have little bit posterior, because if you see the corneal diameter vertical versus horizontal, the horizontal it is always more, temporal incision has a more advantageous in our, so to say, Indian cornea or Bengal cornea is smaller in size. If I go a little posterior, my internal incision will be, controlled way, will be outside your template mark. So you should have working zone 1 millimeter on all sides. Temporal, they have advantage. Superior, it is disadvantage, but if I go little posterior, I get more areas. That is my explanation.
Ideally, when we train people and they want to start, we tell them to do a temporal incision, because you don't have the brow or something which affects, and you have a much better working area. And as you rightly pointed out, the diameter is slightly wider. So when you put in your graft, you don't have the problem of, partially the graft is still stuck in your cannula and not going out. If we have, I think we still have time, I can just show a 2-minute video. This is something again related to the Dmek surgery. Can I have my, yeah. So this is, I found a backflush cannula from the retinal surgeons, very useful for this. So the always problem has been putting an air bubble, whether you put it during your stamping procedure where you fold the DM and you try to put an air bubble, using a 1 ml syringe, or once you're putting your graft into the anterior chamber and then trying to put an air bubble, below the DM scroll. If you're not very careful, the air bubble can displace the graft. So what we did was, so air is quite important. So let me try. I think I skipped the part. Yeah, that's the role, is basically to allow stamping and to assist the unfolding. And in Dmek, it can be quite challenging in the learning curve. And so these are different scenarios where we put an air bubble. So this is when I was trying this technique, and when I use a 1 ml syringe also, sometimes the graft will keep flipping over again and again because you're not able to control the amount of air that releases from the cannula, even if you use a 1 ml syringe. And you can see you get multiple bubbles. So it's not so we got a backflush cannula, connected a 30 gauge cannula to the tip. And when you press that reservoir on the backflush handle, it releases a very small air bubble from the tip. It's not a very expensive device. Madhu Instrument makes this, costs only about 400 rupees for the disposable handle. Now you can see that when you press that, you get a very controlled small air bubble, which is very easy. So you can use this step to go ahead and do the stamping of the donor. And the same thing you can do when you have your graft, which is open inside the eye. You can see that in multiple cases when you just put it, you can just put a very small air bubble in a very controlled manner. You don't have to worry about, having excess air. You can always get the right amount, no matter how many times you do it. It's a very repeatable scenario where a small air bubble. Even once your graft is inside the eye, you go there and you can leave a small air bubble without displacing your donor. So I think in your learning curve of Dmek surgery, even for your marking and loading and, unfolding the graft, please get this backflush handle, not very expensive, and you will find it extremely useful during your Dmek surgery, especially when you just want to put a controlled small air bubble. Always, once you have it, then you can go back and you can enlarge the bubble to the desired size. So that's just what I wanted to show, something that I do in my practice, so I thought that I should make lives easier for rest of the people.
Yes, sir.
Yes, please.
So I would be talking to you about intraoperative OCT guided Dmek or testament membrane endothelial keratoplasty. There are no financial or proprietary interests, and this does have a role to play because it is a non-invasive diagnostic technique that renders an in vivo cross-sectional view of the optical tissue. The one that we have is the microscope integrated OCT, in which you can actually see real-time images and allows a dynamic visualization of both the planar and the cross-sectional views of surgical field, which is available to through the surgeon through the same eyepiece. Now, as far as the donor dissection is concerned, there is nothing much to it, and this is the technique that we are doing, following essentially Dr. Samar Basak's technique of Dmek, because we've been taught by him. And except for the fact that in case you are using a pseudophakic eye, and if there is an incision which is there, there might be some scarring, and that can be picked up on the intraop OCT microscope. Otherwise, apart from that, I have not found it to be very useful as far as the donor dissection is concerned, because the trypan blue staining of the donor cornea itself helps a lot. This is just to show how we make that area where the stamp has to be put after trepanating this stromal tissue, and make a S mark over there so that you can see it later on. And then the whole corneoscleral graft is flipped, and the Descemet's membrane is then taken and is put into the Petri dish. This is a case, in fact, of Fuchs dystrophy with cataract, where cataract surgery has been done. So intraop OCT would help you when you're doing Descemet's membrane scoring. Here it can be easily seen because the cornea is quite clear. But there may be situations where the cornea is hazy, and in those situations, if there are any tags which are remaining, they are visualized very well. Now, once you inject the graft, your biceps curl has to be upward like this. But notice here, this has not been stamped, there's no S-shaped, and this is upside down. So you can just inject a bolus of fluid and get it as the biceps curl upwards, and now you know that there is a gap there. Just put air bubble and the graft gets attached to the back of the cornea. This is to show in the post-operative period the same case where Dmek triple was done in a case of Fuchs dystrophy with cataract. Now, in hazy media we've published, it plays a very important role because their S stamp you may not be able to see. And notice in this case, there are adhesions which are present, which again cannot be visualized, but you can visualize them here and make out whether these adhesions have been removed or not when you're doing desmetorexis. And the graft is now put inside. And again, you have to get that configuration like this, biceps curl upwards. Now, this is giving you a simulation of biceps curl upwards. So you just tap, tap, tap from the side port, egress out the fluid, and then when it comes into a correct configuration, just inject the air bubble. This is in the post-operative period, the same case. Now, in hazy cornea, there may be a problem. This was a very hazy cornea in which you're trying to do a Dmek, and Dmek scroll orientation under the IOCT, like I've told you earlier, this is the correct configuration which is there. So again, if this is hazy, you can see a very faint S which is there, which confirms that this is the correct orientation in fact. And again, put the air bubble there when it's in the correct configuration, and as the graft gets attached to the back of the cornea, the S would become even more clear, and then you can even put a blob of viscoelastic on the surface. It will magnify for a split of a second. There may be folds in the Descemet's membrane when you are putting the air bubble, like in this case. So the Descemet's membrane roll has been put there, and notice that there is a fold which is present onto one side. So inject the fluid above the graft. So simultaneously the air bubble has to be below the graft, but the fluid has to be injected above the graft. You can see the fold which is here. So as soon as you inject the fold above the graft unfolds itself, and then air bubble can be instilled so that the correct side is now up. Now, in eye syndrome, it helps because additionally you have to see, also look at the adhesions which are there, and these adhesions are released after you see them. Otherwise also they can be released, but it just helps you to see it better when you're releasing it. Then desmetorexis is done in this case, and again there may be some remnants which may be still attached to the iris, which can be visualized here. Otherwise the steps essentially remain the same. Get the graft inside, and then put an air bubble so that the graft gets attached to the back of the cornea. Now, this is just to show Dmek and ICE syndrome in the post-operative period. This is a case of Dmek for failed DSEC post-penetrating keratoplasty, and in this, the adhesions are present with the DSEC graft here, which are again visualized very well on the intraop OCT microscope also. And then subsequently, after removing this, I like to load it in this direction only, where the biceps curl is already upwards, so it doesn't go down. And if you can look at it, otherwise also it can be seen, it becomes a little easier because then you just don't have to do anything except tap 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 and put air bubble. Of course, the correct S is also staring at you, so you know that you are absolutely in the correct direction. Now, this is what I called as auto DMAC. What had happened was that a surgeon was trying to do phacoemulsification. The whole disc came out, and the surgeon just pushed the disc back and referred the patient to us. So the very same day we took up this case because we didn't want to cause more compromise of the cornea. And then now, because this is not stamped, you can't make out which side is up and which side is down. So what was done is that this was, of course, referred as a desmet membrane detachment case. And what we did was that we again just looked at the IOCT picture to know which side is up. And when we had that simulation of the biceps curl upwards, we injected the air because that thing is looking to be curled upwards. So after injecting the air to the back of the cornea, and I called it auto DMEC because this is the patient's own Desmet's membrane which has come out and it has been pushed back by the surgeon and referred to our center for taking care of the DMD. Now, this is just the last bit to show what the DMAC problems can be. Sometimes the scroll is rushing somewhere and you are rushing after the scroll and it kind of doesn't oblige you. So, important thing is just to know that if you are far away from it, that swirl will be created and you keep pushing it in front. So, it is important that you are not far away from it so that those whirls of pools are not generated to push it up. And one has to engage the DMEC scroll parallel to the tip of the injector so that and go close to it so that you can actually get it into your syringe. So that this is some people use a air bubble also to lock it so that it doesn't come out, and then later on the air bubble can be removed subsequently. Now, this is to show another case where you don't have to do anything. It's a older graft, so it is just waiting to fall out like an umbrella, and you don't have to do much. It just unfolds and unfurls itself. At times, this one should never do. Look at the way the injection is being done. Uh, it is not perfect because it is kind of oblique and the fluid is going first and the graft is coming out. So this is inadequate docking into the wound which is causing problems. So if you have an inadequate dock, there will be a space, it will come out. But if the dock is adequate, then it is not going to come out. So if the dock is adequate, you have to sort of make a tunnel which kind of goes in, through which the graft goes out, and put that cannula immediately as soon as you do this. And this is again the partial evacuation of the graft that can be seen. Immediate temptation is to just push it back in as has been done because you don't want it to come out and then redo the whole thing. And this has happened after the graft was already in position. So extrusion of the DMEC lenticule is happening. And again, it is important to know where you are pushing your fluid. So if your fluid goes beyond that area, then it's going to be a problem. So this, I think I've already shown you. If you don't have an intraop OCT microscope, then you can also do with the slit beam. And with the slit beam, notice again, you can see the biceps curl upwards. And once that is there, then you know that you are in the correct direction. So to conclude, intraoperative OCT is a useful tool in the armamentarium of keratoplasty surgeons, and it does help to refine your DMEC surgery and helps to see the unseen. Of course, modifications and quantifications are required in the current system for accuracy. Thank you very much for your kind attention.
Thank you, Namrata, for a wonderful talk and a lot of tips. Any question from the audience to Dr. Namrata Sharma? Any comments? Okay, we'll take the questions later on. Rebati, Dr. Rebati, you will be speaking on complication due to landing curve.
I think some of the videos she was showing, the DM scroll was not stained very densely like what we usually do. And I think that's because if you have the intra-op OCT where you can see the orientation of the scroll, you don't really need to do a dense trypan blue staining of the graft.
Mic, please.
On only. Now it's on. Yeah. Thank you. The next few minutes we will see some of the problems one may face during the learning curve. The first one is while preparing the tissue. So generally we try to go for a little older tissue so that unscrolling will be easier for us in the learning time. But these tissues can be very fragile and they can easily torn when preparing the tissue, donor tissue. And the advantage is like even if there is a small tag or tear, or even Dr. Fogla once in one of the talks mentioned about 80% of the tissue is there. Still you can go ahead and with the Dmek, so still you can get good results. So if you get a small tear, don't get discouraged and switch over. You can still try to use it if you have at least a decent large graft. And next one, to prepare the
You are a new
recipient
Matthew.
area,
Matthew is
we have to
absent.
remember DMAC is
Okay,
little unforgiving.
if I
So
need,
you should not have any
I'll
tags in
talk after
between
some
while
time.
opposing the
Okay,
donor tissue
okay,
to
I'll
the
call.
recipient area. So here I learned like if you do it under air, you can see the margin very clearly. But if you are not able to do it, in some cases we can't do. If you do it under visco, wash it off and then put an air bubble and verify the margins are all around clear and there are no tags. We have to remove them. Then the donor tissue insertion, already we have seen few of these. You have to depressure the anterior chamber before taking the cannula out, the cartridge out. If you don't do that, with the pressure, easily the donor tissue can come out. And then, of course, luckily in this case, later it was again sorted out and again re-injected. Luckily, it escaped. But all the time, we will not be very lucky like that. Then sometimes we may need a backup tissue also. Sometimes being too cautious also will be a problem. So especially like if you have a long arm of the injector and you keep on checking it without concentrating on the thing, suddenly it came out. So that also is another problem. So all these manipulations are going to reduce your endothelial count. So we have to be very careful in avoiding all these manipulations. And poor visualization, as just now Dr. Fogla mentioned, sometimes if the uh, staining is not good, or if the media is, the cornea is too hazy, then again we will have problem, as in this case. And here you can see, like, you can see vaguely a triangle of tissue, and the surgeon tried to, after injecting, try to unfurl, that's it. It has gone behind the pupil. And even to recognize that is very difficult in such a cornea, especially if the staining is poor. And then we may need additional instruments like either intraoperative or maybe outsourced light we need to find it out. Then the scroll management is already mentioned by Dr. Fogla. Most of my topic is already covered when they were showing these things. A tight scroll, what I learned, we can use Fogla's cannula and go in if we are very confident about the orientation, then we can go in and with a jet of fluid, we can unscroll and then we can do it. And the same way we can, a large scroll, a large graft. Initially, like we tend to make very large grafts thinking like we are replacing large amount of endothelium. Then again, this they can get folded like a origami and then managing will be difficult. Instead of that, like Dr. Basak shows, going for a peripheral cut, peripheral punch will give more endothelial cells. Then the sticky tissue is a major problem. I don't have a video exactly to show what a mess it can be. But whenever you get bleeding like this, always wait for the bleeding to completely stop and then go ahead and do the tissue injection. And then again, Dr. Fogla mentioned this open edge we have to verify before injecting, then only we can get the correct orientation in the anterior chamber. And a decentered graft, this is again another one I want to insist, like it is not like DSEC. Once you see a decentered graft, you can't just tap and bring it, it's quite difficult. So again, sometimes we have to deflate partially and then slowly we have to bring it to the center. Unlike the DSEC tissue, this is not easy to manipulate. And sometimes a large PA can be a big problem. And this video I have shown previously also. If you inject, the air can go through the PA posteriorly, so that can be a big problem. So nowadays, I try to avoid a very small PA. Sometimes even there are reports that even without PA you can do cases. The postoperative complications in the initial period, of course, pupillary block glaucoma we have to keep in mind, and it has to be released as soon as possible, air bubble. And also dislocation of the graft, which is also more common here. And this, the ASOCT will be very helpful to make sure that it is correctly oriented, and usually it will be more in the first 1 week. So during this 1 week, keep on assess the patient, and even if a localized edema persists, go and do an ASOC to find any peripheral detachment and then address it immediately. And primary graft failure also common in the learning period, usually due to manipulation. And also when you are switching over from normal cases to more complicated cases like IC and all, then again we will get into trouble and we'll have more manipulation and primary failure. And graft rejection is, we have to keep in mind, very quite difficult to recognize in these cases, not unlike in PKP. So here we have to be very careful. Even few new freshly appearing KPs or AC cells should trigger a suspicion, and then we have to treat it as graft rejection. And graft infection, luckily in our country, we are not seeing more infection compared to PK here, because we prepare our tissues freshly. But in Western countries where prepared tissues are being distributed, they feel that their infection in EK is more than the PKP. So this we have to keep in mind as we are slowly moving to tissue distribution system. So in conclusion, this is a very elegant surgery with elegant results, but the learning curve is steep. And we have to understand, if you are a DSEC surgeon, when you are switching over, this is a different surgery. So we have to de-learn something and we have to acquire newer skills. And we can't apply the same principles sometimes to manage the issues here. Thank you.
Thank you, Dr. Repti. So again, the question is open for all of our speakers. So if you have any questions. No questions? Oh, yes. Who is there? Mar is there. Meena. Oh, Meena is there, yes.
So I have two questions, and one is, while you were peeling the donor, I have been taught like we should do the scuba technique submerged in fluid, but actually you didn't develop any tears even when you didn't have fluid. It's a question for you.
Me?
Yes.
I never use scuba
Fluid.
technique.
Okay. So
Because
the
whatever I have understood, scuba technique is taking long time. Whatever I read earlier, I have never tried.
No, so scuba kind of confuses you also, because it's fluid, so it keeps, it's not static there. So when you take it out,
I have seen one. You told me.
we do what you do, so we do the same way. We don't use scuba technique.
Scuba I have never. Rajesh.
No, I like to protect my endothelium. What you have shown, you are very fast, so you don't allow the endothelium to dry. But if you see one of the other people doing it, if they take longer, you will have the endothelium drying up, and when you are doing that, so I think it's always better that it doesn't have to be done under floating and fluid, what the original scuba does, but at least keep a little level of fluid so that your decimus remains moist when you are doing that. And also if you keep a little bit of fluid, you have easily, you can move the decimus much more easily rather than it getting folded and getting fixed folds.
So I think, sir, even yours is not absolutely dry. There's some
No,
film of fluid.
It is a fluid. It never absolutely
Yeah.
dry.
Scuba
is some
technique was
film.
originally submerged in
Full
the,
submerged. I know.
Whole submerged.
so there even the sclera you had to hold. So what you will see in his videos and my videos, we never use a two-handed technique. We are not fixing the sclera when we are doing the peeling, because when you do that, you will not be able to assess the resistance. So that's why the tissue is lying in the endothelial punch block, and you are using one hand to peel without providing any counter traction. So the moment you come and encounter a resistance, you can see movement of the corneoscleral rim, and you know that there is a abnormal adhesions. So I think that's very important to see.
So isn't your second hand holding the scleral?
No. Always remove the excess fluid from below the corneoscleral rim, because if there's too much of fluid, then the
moves.
cornea will keep moving. So you first dry the base, put in your corneoscleral disc, and then you single-handedly do that. But don't try to hold and do that, because if you hold and do that, you will definitely tear your tissue.
So the second question was of centration of the Dmek tissue. Sometimes I feel it overlaps with the area of stripping. So Dr. Samar, you said that you are oversizing the host area by 0.5. Traditionally, we have been doing the same size. So I just wanted to know.
Same size for Dmek? No. Same size for Dissec, even smaller size for Dissec is okay. But Dmek, I prefer 0.5 or maybe point, depending upon the size of the cornea. So 0.5 is, and you can actually see that when you are giving air bubble, you can see the margin and also DM edges, the torn DM edges. Usually it fits cover. If it crosses little like 5%, it doesn't matter.
Doesn't matter.
But again, where is that gap? Is it in the lower part or it is in the upper part? Lower part, it matters because fluid start from there. Upper part, the air remains for a longer period of time. So patient sits, reclining, the upper part air stays there and it gives. But lower part, there may be, it is my thought, but donor detachment nowadays it is very, very less. I mean, it is less than 2% in my hand. I do not know, Rajesh.
In my hands, it's still about 8%.
8?
Yes. Maybe it's the kind of tight airfill that you do. 8% in the sense because I do more of complex cases.
No, I
So
do
maybe,
lot of complex
yeah,
cases.
so these are all post-tube straps, those kind of
What
scenarios.
I have understood, I am sharing during, we used to keep the patient overnight before COVID. And we used to see the patient next day, everything fine, fluid bubble, we send home. And during COVID, what happens? We stopped keeping the patient at night. So we send the patient home and ask the patient to come on third day. First day detachment, second day detachment is not a, hota hi nahi hai. Basically, it doesn't happen. First post-op is useless actually. You see only certain other things rather than donor detachment. But third day is very crucial because the air bubble is say 40% level or 30% level, and that time you actually see your detachment. So third day, then day 7 is fine. So this is my
when you say detachment, I mean don't mean complete detachment.
No.
You get peripheral detachment which you observe and it settles down on your own. But even then, if you get a partial peripheral detachment, these patients have to be followed up because they can progress and the detachments can increase. But the rebubbling rate would be in the range of 2%, 3%.
No, my overall.
Where you actually go and put in an air bubble. But like I said, that the centration of the DM graft sometimes may not be perfect. It will not exactly be in the bare area that you have put. I have learned that sometimes less is more. So if you have opened your graft and your graft is fairly covering the pupillary area, even if it is slightly decentered on one side and you're losing your stain, it's better to put an air bubble and complete the surgery there than to try and detach it again, try to move, because what happens is by then the stain becomes lighter and often you realize that you end up in a more worse situation than what you started off with.
So there is a saying, Do not try to be 100% perfect in Dmek surgery. Do not try to be 100% perfect in centration as we used to do in DSEC. So little eccentric, let them. But if it is too much eccentric, then you need to take a call and you need to. And I have some videos, probably next time I send. How do you, what Rajesh, I have devised some instrument. You can, without, making the re-scroll again, you can actually shift the graft by various instrument. I have 3-4 such kind of instrument, and I often do that. So probably next time I will show that.
Complex Dmex. I think
So
our
you
time is
may
up.
not de-scroll it again, re-scroll it.
No
Reduce
re-scroll.
the amount of air.
Here, give little fluid, and now you can manipulate with and retina people's instrument helps a
Correct,
lot
correct.
here. Okay, thank you very much. Thank you.